These recordings are copyrighted material under U.S. copyright law. Federal law provides severe civil and criminal penalties for unauthorized reproduction, distribution, and exhibition. The purchaser agrees that these recordings will not be duplicated in any manner, nor will they be circulated outside the physical location of the purchaser to which the recordings were sent, without the written permission of FTC Reports Incorporated. The purchaser further agrees that it will not resell or make an exchange of any kind of these recordings. The information contained in these recordings should be an accurate and complete record of the public portions of the FDA Advisory Committee meetings. However, FTC Reports Incorporated assumes no liability for the accuracy and comprehensiveness of the information presented.
Good morning. I would like to call this meeting back to order. The Executive Secretary will again read the Conflict of Interest Statement for the meeting.
Thank you, Chairman Burton. This is Michael Jota, Executive Secretary of the Dental Products Panel. The Food and Drug Administration is convening today's meeting of the Dental Products Panel, the Medical Devices Advisory Committee, the Center for Devices and Radiological Health, and the Peripheral and Central Nervous System Drugs Advisory Committee of the Center for Drug Evaluation and Research on the authority of the Federal Advisory Committee Act of 1972. This will be a joint meeting of two committees. With the exception of the industry representative, all members and consultants of the committee are special government employees or regular federal employees from other agencies and are subject to federal conflict of interest laws and regulations. The following information on the status of the committee's compliance with federal ethics and conflict of interest laws covered by, but not limited to, those found in 18 U.S.C. Section 208 are being provided to the participants today in today's meeting and to the public. FDA has determined that members and consultants of these committees are in compliance with federal ethics and conflict of interest laws under 18 U.S.C. 208. Congress has authorized FDA to grant waivers to special government employees who have financial conflicts when it has been determined that the agency's need for a particular individual's services outweighs his or her potential financial conflicts of interest. Members and consultants of these committees who are special government employees at today's meetings have been screened for their potential financial conflicts of interest of their own as well as those imputed to them, including their employer, spouse, or minor child related to discussions of today's meeting. These interests include investments, consulting, expert witness testimony, contracts, grants, creators, teaching and speaking, writings, patents, and royalties, and primary employment. Today's agenda involves a review and discussion of the peer-reviewed scientific literature on dental amalgam and its potential mercury toxicity, specifically as it relates to neurotoxic effects. Based on the agenda for today's meeting and all financial interests reported to the members and consultants of the committees, conflict of interest waivers have been issued in accordance with 18 U.S.C. 208 to Drs. Larry Goldstein and Sandra Olson. The waivers allow these individuals to participate fully in today's deliberations. Copies of these waivers may be obtained by visiting the agency's website or by submitting written materials to the Freedom of Information Office, room 630 of the Park Lawn Building. A copy of this statement is available for review at the registration table during this meeting and will be included as part of the official transcript. Dr. Mason Diamond is serving as a device industry representative acting on behalf of all related industry and is employed by Thai RX Pharma Incorporated. Dr. Roger Porter is serving as a drug industry representative acting on behalf of all related industry and is a retired employee of Wyeth Research. Dr. Rodway Mackard, who is a guest speaker for us, has acknowledged the financial interest in and professional relationship with a firm at issue. We'd like to remind members and consultants that if the discussions involve any other products or firms not already in the agenda for which an FDA participant has a personal or imputed financial interest, the participants need to exclude themselves from such involvement, and the exclusion will be noted for the record. FDA encourages all participants to advise the committees of any financial relationships that they may have with any firms at issue. Thank you.
Thank you, Mr. Ajota. The first item on our agenda this morning is the open public hearing. I'll read in some information prior to starting that portion. This is the second of our two open public hearing sessions for this meeting. The first open public session here was held yesterday afternoon. Repeating what was said then, at these times, public attendees are given the opportunity to address the committee to present data or views relevant to the committee's activities. The FDA does value your input. Members of the public have an opportunity to speak to the committee at the public meeting, but practical considerations limit the time that we allocate to public speakers as a group, and therefore to any individual speaker. For this reason, the FDA has established a docket, FDA docket number 2006-N0352, for all interested members of the public to submit written comments of any length to the FDA. Those will be reviewed in addition to the oral testimony to see what light can shed on the questions and issues being raised at this meeting. The FDA is especially welcoming of public comments about the peer-reviewed scientific literature on dental amalgam and its potential neurotoxicity, specifically as it relates to neurotoxic effects. Based on the number of requests we have received and the material covered yesterday, to allow adequate time for our deliberations, we have allotted each speaker 7 minutes for his or her presentation, as we did during yesterday's session. Those of you who have registered to speak have been given a number corresponding to your order of appearance. When it's your time, please come to the podium area in advance so that all reduce the transition time between speakers and keep it to a minimum. The FDA staff will direct you to the appropriate podium. Please remain within your time constraints. There are many speakers and the time limits have been and will be strictly enforced. We will use the timer again for this meeting. The yellow light will signal you and you have 1 minute left to finish your presentation, and we will make an audible notification as well. The red light means that your time is up and you will be cut off at that point in time. Both the FDA and the public believe in a transparent process for information gathering and decision making. To ensure such transparency at the open public hearing session of the advisory committee meeting, the FDA believes that it is important to understand the context of an individual's presentation. For this reason, the FDA encourages you, the open public hearing speaker, at the beginning of your written oral statement to advise the committee of any financial relationship that you may have with any company or organization that may be affected by the topic of this meeting. For example, this financial information may include the company's or organization's payment of your travel, lodging, or other expenses in connection with your attendance at the meeting. Likewise, the FDA encourages you at the beginning of your statement to advise the committee if you do not have any such financial relationships. If you choose, however, not to address this issue of financial relationships at the beginning of your statement, it will not preclude you from speaking. I would like to remind the public observers at this meeting that while this portion of the meeting is open to public observation, public attendees may not participate except at the specific request of the chair. Also, the chair and other members of the committee may question a person about his or her presentation. No other person may question the presenter or interrupt the presentation of any other participant. I ask that the speakers bring only their written comments or presentation materials to the podium. And again, please state your name for the record and begin with a financial disclosure. Our first speaker this morning is Mr. Michael Bender. Is he present?
Good morning. Thank you, Mr. Chair, members of the committee, for the opportunity to present here this morning. My name is Michael Bender, and I'm the director of the Mercury Policy Project. We work on both domestic and international mercury-related issues to reduce both release and exposure of mercury. In my talk today, I will be focusing on a 2005 Norwegian Broadcasting documentary examining complaints by dental nurses. The reports of high mercury exposure are shocking. That you'll see in the documentary excerpts that my assistant will be showing directly after my presentation. The responses by dental nurses to the airing of the documentary was that their offspring were affected too. So therefore, we have two common sense recommendations. Ban amalgam placement during pregnancy, as a number of countries, including Health Canada and Britain and Germany, etc., have already done, and place dental nurses on paid leave during pregnancies. The 2005 Norwegian Broadcasting documentary investigated a number of dental nurses' complaints, including tremors, memory and concentration problems, liver and kidney problems, and many others that I don't have time to go into at this point, but copies of my presentation are available afterwards. The study results that you see show that their investigation found that 25% of dental nurses reported having neurological problems and many other problems as well. There were a number of experts who claimed that there was no possible way that these kind of effects could be experienced with these mercury levels. And so following the procedure used in the past in the dental office, amalgam was heated and the results were staggering. Every time amalgam was prepared, the meter was spiked to the maximum limit the device measures. A similar situation occurred in New Zealand in a study that was documented in 1974, where New Zealand nurses were exposed to similar levels of mercury, and they and their children experienced similar effects. After the documentary ran in Norway, around 400 women, former dental assistants, called the television station. A pattern emerged. Many worked while pregnant and were also breastfeeding. A high number reported children born with birth defects, learning disabilities, immunological musculoskeletal problems. Mothers had severe bleedings and multiple late abortions. The documentary was also then shown in Denmark, and more than 1,650 dental nurses have called the Danish trade union expressing concerns for both their health and the health of their children. As a result, the Danish Employment Agency and other federal government agencies in Norway and Denmark have gotten together, and they are now committing a multi-million-dollar, multi-year study to neurotoxic mercury exposure effects on dental assistants and dentists as well, investigating what went wrong, who was affected, and how badly. Norway now actively discourages dentists from placing amalgam, and I did meet with, when I was over in Scandinavian countries in June, I did meet with the authorities for the government authorities on dental mercury. In Norway, amalgam placement takes, it's recognized that amalgam placement takes away from the life of the tooth. And if you, I'm co-chair of the State of Vermont Advisory Committee on Mercury Pollution, and when we talk to our Vermont dentists, they tell us the same thing. This is common knowledge, setting aside the toxicity issues. Second, the levels of mercury in pregnant women and children are far too high, as we know from the EPA interpretation of the CDC data. 1 in 6 or 1 in 8 mothers or expectant mothers have blood mercury levels far above what's considered safe. When sure, it's important to follow the when unsure, it's important to cover the precautionary principle and the principle of product substitution. When available, use less toxic materials. And again, amalgam is banned, placement is banned during pregnancy. While the levels of mercury in the past were much higher in Norway than they are in the U.S. today, recent research of 6,000 U.S. dentists and dental assistants with exposure to lower levels of mercury below the WHO standard still resulted in measurable neurological damage detectable in neuropsychological tests. Some, Mr. Chair, an ounce of prevention is worth a pound of cure, especially when it comes to protecting the most vulnerable, the unborn who have no say over this matter. Therefore, please consider the following common sense recommendations. While almost everyone agrees that the developing fetus is most susceptible to mercury, we need to do more to reduce maternal exposure, and the FDA is doing this, starting to do this quite well with methylmercury exposure in fish. Except in emergencies, FDA should ban mercury tooth fillings placements during pregnancies. And again, dental nurses should be placed on paid leave during and just prior to pregnancies. As a result of the showing of this in Norway, the journalists who are here today were presented the most prestigious Norwegian journalistic prize for their documentaries on dental mercury exposure. The judge's statement: after the two journalists' impressive and extensive work, our perceptions of what 10,000 dental nurses were exposed to in their workplace has been changed forever. There was also an award given to the dental assistant Tordis Clausen by the Norwegian Society for Civilian Courage. She was recognized for her tireless work to acquire and spread information about health damage resulting from exposure to dental amalgam and mercury in dental clinics. Ms. Clausen lost a civil lawsuit in 1997 and 1999 for compensation, then appealed all the way to the Norwegian Supreme Court and was then denied. She has since appealed to the European. Go ahead. Oh, sorry. Okay. Has since appealed to the European Court of Human Rights in Strasbourg. And the Zola Prize winner is awarded to persons who, quote, openly and courageously have revealed or opposed conditions in Norway that threaten basic values in Norwegian society, human rights, democracy, and legal protection. I'd like to acknowledge the following, and also in your handouts is information. I do have a copy that I'd like to submit for the record of both Mercury Girls and also Mercury Children, and you'll be seeing excerpts from primarily from Mercury Girls next. Thank you very much.
Thank you. Our next presenter is Dr. Rachel Obard.
Good morning. My name is Rachel Aubard, and I'm a science advisor working for the Mercury Policy Project. I have no financial conflicts of interest. Michael Bender and I obtained the film Mercury Girls from Tordis Clausen, a former dental nurse, and one of its subjects, while in Norway this past June. The film, as Michael tells you, was produced by independent filmmakers in Norway and shown on public television there. The original 29-minute film has been cut to the 7 minutes I will show you, and as a result has a rather abrupt ending.
Dette 70% kvikksølv.
70% mercury.
Vi I ferd med å lage
We're making amalgam
på
the
gamle
traditional
måten.
way. When heated, the mercury appears. The most dangerous element is invisible, the vapor. 80% is absorbed by the lungs and distributed around the body. Some of it ends up in the brain, where it is accumulated. This program is not about teeth. It's about those who handled mercury daily in dentist offices. At least 10,000 women worked as dental nurses in 1960 to 1990. What they did on a daily basis, no one would dare today. In Stockholm, we see Mathis Berlin, environmental medicine professor. His special field is mercury. He has contributed to establishing the WHO limits. Berlin confirms the difficulty of settling on a diagnosis. Physicians have little knowledge of the hazards of mercury, he says. If you are poisoned, they tend to think you have mental disorders. And mercury does lead to an unbalance in the brain. Berlin is well aware of the dental nurses. He thinks many have inhaled too much mercury. He thinks even today's limits are too high. 0 exposure is best, he says. All biological organisms are sensitive to mercury. In Seattle, we find some of the world's leading mercury experts. I'm going to want the sound back on for this place. Jerome. Okay. They're associated with the research organization Battelle. In the USA, they carry out A lot of assignments from the authorities. The dental personnel examined here were exposed to very low doses of mercury, 10 times lower than what was common among personnel in Norway until the 90s. Even so, there are damages. Can you turn the sound back on for the film?
Down. A person's capacity to hold something steadily, very, very firmly in their fingers and not jiggle and not move this way or this way is impaired when someone has a fair amount of exposure to mercury. A person's ability to recall numbers is worse, so their attention is lower. We see increased symptomology, not across the board, mostly in complaints of memory loss and concentration, okay, and anxiety. We see some mood, some depression.
Dette er Nils Roar Gjerde, professor.
This is Niels Roar-Gurset, professor of odontology in Bergen. Deep inside a cupboard, he has found copper amalgam. We'll try to find out how much mercury is released when we do what the nurses did several times a day. The difference is we've got gloves and a hood. We've brought an occupational hygiene expert to the survey. In Norway, 50 micrograms during a workday is permitted. 36 micrograms per cubic meter is the reading. Measure now with the mercury on the surface. Then I will transfer this to a mortar. This is beyond the level I'm able to measure. It's more than 1,000 micrograms per cubic meter. When we blend it here, yes. Every time the meter said high level. More than 1,000 micrograms. We don't know how much more. The Section for Occupational Medicine in Bergen has carried out a study on initiative from Brennpunkt. All the nurses who were tested worked between 1960 and 1990. 25% report frequent or very frequent neurological problems. They are compared with a group of nurse assistants of the same age. The dental nurses score more than the nurse assistants in 4 fields. Tremors, dental nurses 36%, nurse assistants 8%. Heart and lung problems, dental nurses 21%, nurse assistants 5%. Depression, dental nurses 18%, dental nurse assistants 4%, and loss of memory 14%. Nursing training. The girls radiate joy and awe. They are dental nurse students and their future is secured. They will learn a modern trade. For 2 years, they are taught how to knead mercury and boil copper amalgam. They do not know that alarmingly many of them will develop uterine problems. Oh, sorry.
Reported having a hysterectomy, whereas in the control group, their sisters and their friends, it was 6%. So that's a very big difference. It was statistically significant, but it's also much higher than I would expect in the normal population in New Zealand.
We'll need to stop at this time. Thank you.
The part that you missed was that the dental hygienists, 25% of them had hysterectomies versus 6% in the control group. Thank you for your attention.
Thank you for your testimony. Our next speaker are Mr. and Mrs. Michael and Phyllis Burke.
Good morning, everyone. I'm Michael Burke. This is my wife, Phyllis. We have no financial contributors. Phyllis was diagnosed on July 29, 2004, with early onset Alzheimer's disease by our traditional neurologist, MD. Most recently, our MD in Chicago, Dr. Thomas Stone, a very famous doctor there, agreed with that assessment. However, his root cause diagnosis was, in fact, heavy metal toxicity. Thus far, in an attempt to save her life, I have studied over 3,000 plus hours on this subject. It's my firm conviction that the bioaccumulated mercury vapor coming off of one's mercury fillings over the course of many years is in fact the primary causative trigger for Alzheimer's disease. Following are but 4 crucial interlocking puzzle pieces I uncovered. Alzheimer's disease is most prevalent in industrialized nations. These are countries where dentistry using mercury amalgam fillings is common practice. Alzheimer's barely exists, if at all. In third world nations, there are many sources that back this up. In 1993, a groundbreaking study by Duke University revealed that the presence of just one ApoE4 gene significantly increases Alzheimer's risk and also lowers the age of onset. My wife took a blood test and it confirmed her as being the worst case scenario, ApoE44. Both her ApoE genes are 4s. Excuse me. According to Dr. Boyd Haley, the unprotective ApoE4 form has 4 arginine amino acids located on the potential mercury binding positions, as opposed to the very protective ApoE2, in which there are 2 cysteine amino acids present, or the semi-protective ApoE3, where there's 1 cysteine and 1 arginine. It is no more than basic chemistry we're talking about here. Mercury loves sulfur. Mercury binds preferentially to sulfur over almost any other element. The cysteines present in the protective ApoE3 and the semi-protective ApoE2, or the protective ApoE2 and semi-protective ApoE3 are sulfur-based amino acids, and thus readily attract, bind, and excrete mercury on a continual basis 24/7. An ApoE2 status would easily explain why someone might be 70 years old and have a mouthful of amalgam fillings but never reach a state of intellectual compromise. Conversely, there is absolutely no chemical affinity for mercury by the arginines on ApoE4. ApoE4 genes only allow individuals to hyperbioaccumulate mercury 24/7. This more than adequately explains Duke's previously mentioned findings. Every aberrant diagnostic physiological change that occurs in the brain cells and neurons of Alzheimer's victims has been identically recreated by Dr. Boyd Haley and colleagues in strict laboratory settings by exposing live nerve cells to very low levels of mercury. Please note, many other metals have been tested, including aluminum. None of them reproduced any of the hallmark diagnostic changes. In my wife's particular case, this next point is critical. Mercury fillings can and do carry electrical charges. The higher the negative electrical charge, the more mercury is being released from the amalgam. While having only 2 amalgam fillings, Phyllis had 1 filling that registered a negative 316 microamp charge on a device called the Ritometer, specifically for measuring the charges on amalgam fillings. When I spoke personally to Dr. Hal Huggins and relayed this fact to him, he has been incredulous with disbelief. He had never heard of, seen anything remotely close to this high a reading for a negative charge being registered on an amalgam surface. Both he and Dr. Boyd Haley personally conveyed to me that because of this high negative electrical charge, this particular amalgam was extremely toxic and it was giving off tremendous amounts of mercury. Dr. Huggins stated also that perhaps even in the form of more deadly methyl mercury. Now, I'd like to share a few items with you. I call it my reasonably intelligent person's top 10 list why mercury should not be used in dentistry and medicine. And I'm just going to do a few of the highlights. On this planet, mercury is second only to the radioactive element plutonium in its ability to do neurological damage. Pink disease was from the late 1880s to about 1950. It killed thousands and thousands of babies worldwide. When it was discovered finally, yet reluctantly accepted in the late 1940s, early 1950s, that mercury was in infant teething powders, and it was in fact the cause of pink disease. When they took it out, no more babies died. When a dentist fills your teeth with mercury, he or she must handle the excess scraps as a hazardous waste material in accordance with EPA guidelines. Why then is the load of mercury left behind to weather the stormy and turbulent conditions of your mouth any different? What makes it so safe and special? On the flip side of the coin, you then become an EPA-approved toxic waste receptacle. A study done in Glasgow, Scotland, evaluated 180 dentists and 180 volunteers off the street. The dentists as a group scored much lower on the cognitive memory issues as well as physically. Hugh Fudenberg, MD, a world-leading immunogeneticist and biologist with nearly 850 papers published in peer-reviewed journals, has reported that if an individual has had 5 consecutive flu shots in a 10-year period, his or her chances of getting Alzheimer's disease is 10 times higher than if they had 0, 1, or 2 shots. He attributed this to mercury and aluminum present in vaccines. The original dental association in the United States was called the American Society of Dental Surgeons. They refused to use mercury amalgam fillings because they knew they were extremely toxic. However, because many dentists wanted a piece of the mercury amalgam financial pie, they abandoned ship and started using mercury amalgams in patients. As a result, the American Society of Dental Surgeons died on the vine. In 1859, the ADA was formed from these same individuals. The initial statement of the ADA as regards the use of mercury in fillings was that compound was perfectly inert and mercury does not leach off or vaporize. This is a statement that was made with absolutely no scientific evidence to back it up either way. They blatantly disregarded any and all caution as regards mercury.
1 minute.
Even the name silver fillings was deceptive, as by the composition the amalgams contained a much higher mercury content than silver. This was a foot in the door for mercury. The American public trustingly and unknowingly allowed a silently creeping, deadly monster into its everyday world. Unfortunately, subsequent well-meaning dentists were also inherently desensitized by the status quo. Heavy metal, toxic metals, and soft pink human flesh are simply not compatible. In conclusion, I am asking you today to hear my message and do the right, decent, honorable, God-loving thing. There needs to be an immediate embargo upon the placement of mercury fillings in this country, if not for everyone, at least for pregnant women and children, because they represent our future. You need to understand, my wife has the worst case scenario, yet it took 35 to 40 years to manifest. This clearly puts the
Thank you very
children's
much for your input.
studies into perspective. Thank you.
Thank you. Our next presenter is Dr. Howard Baylett.
My name is Howard Baylett. I'm a professor in the Department of Community Medicine at the University of Connecticut, and I'm a dentist and a health services researcher by training. And today I want to present a study that we've done on the economics of regulating amalgam restorations. The investigators are listed here, include myself, are a mixture of the economists, epidemiologists, and people with expertise in operative dentistry. This is sponsored by the California Dental Association and the American Dental Association, but we had complete academic freedom. I have no financial ties to these organizations. They have not reviewed this presentation. This represents our own view of our analysis. And we have prepared a paper that is now being reviewed by a national public health journal. So our objective was this, to estimate the financial impact of banning the use of amalgam restorations. And we did it for 3 cohorts of the population, children and women of childbearing age, and the entire population. There is no national data set that's available that gives the number of amalgams being received by every individual, so we had to make some approximations. We used data from, claim data from Delta Dental of Michigan, which is a carrier and based in Michigan, but also the surrounding states that has large market share. So we're talking about close to 1 million people in this study, each year of the study. And we ran this data from 1992 to 2004. But obviously this is a problem because we have people who only have insurance, so we know that insurance does affect use. So we looked at another data set that came from the American Dental Association, where they survey a sample of dentists and obtained from these dentists the services they provide to their patients. So this is to all patients, insured and not insured. And we know from this analysis that these 2 data sets are in close agreement. The third big methodological issue is coming up with an estimate of the relationship between the price of services and the response in terms of quantity. As price goes up, obviously, the quantity goes down. And we use the elasticity estimate for all dentistry, which is well known because this estimate, because restorative dentistry includes is such a large component of dental services. And we did sensitivity analysis to determine how different elasticity estimates would affect our results. Then we calculated the rate of change in amalgams and fees for the last 12 years. We estimated the per capita amalgam use and then projected that to our national estimates using census data, and then looked at the impact of the ban on these subgroups from 2005 to 2020. Amalgam trends first. In 2005, we project 166 million restorations. About 31% of them would be amalgams, 47% resin composite restorations, and the rest various kinds of cast crowns. Interestingly, for all subgroups and all ages, amalgam use is declining about 3.7% a year. So we've seen over that period a fairly dramatic decline in the use of amalgam, which we assume will continue. The ban is going to have an effect on fees. It's going to increase fees, obviously, because the substitute services, resin composites and crowns are going to be more expensive than amalgams and require more visits. As price goes up, you're going to have fewer restorations. It's going to increase costs. Let me give you an example for the total population. If the ban was for the total population, the average restoration would increase in fees by $52. You'd have 15 million fewer restorations provided in this country. That's about 10% of all restorations. And on the table, on the figure on the right, you see the impact in the first year of the cost of the ban. For the total ban, it would be about $8 billion, and that constitutes about 10% of total dental expenditures this year. For children and women, it would be about $4 billion, and for just children, it would be about $1 billion. In addition, there's an unmeasured impact that we could not measure, but it's important to understand it. First is the announcement effect. Clearly, if you ban it for one subgroup of the population, you're going to cause some patients and some dentists to decrease the use of amalgams and use these substitute services, which will probably increase overall fees for restorations even at a greater rate. Plus, you'd have a significant impact, detrimental impact on oral health, because as price goes up and expenditures go up, you'd find people using fewer services, and this is associated with pain, missing teeth, disability, what have you. And of course, this would increase disparities in access to care because it's the lower income families that would be most affected by these increased in fees and expenditures. And dentist incomes would increase about $3 billion if it was banned on the total population. That's approximately, in gross income, about $20,000 per dentist. So from our view, the amalgam ban is going to increase dental expenditures. I don't think there's any doubt about that. It's going to reduce access and oral health. Based on the New York Times report on your findings yesterday, there's no evidence of amalgams causing ill health. And so our recommendation is do not ban the use of amalgams. Thank you.
Thank you for your input. Our next speaker is Dr. Boyd Haley. You ready, Dr. Haley? Yes. Thank you.
I would say that I have no dog in this fight. I'm nothing but a hardcore scientist that believes in numbers and measuring things. And this first slide is a slide that comes off the internet that's been made several times. It's something that we do in the lab I teach at the University of Kentucky called Mercury Science and Politics. Freshman students do it. And I would point out that if the mercury level came out as estimated by the American Dental Association, you would not be able to see a vapor coming off an amalgam filling in this form. We've also measured this in much more rigorous scientific ways in sealed containers, and the mercury comes off quite rapidly, and it's very simple. A freshman chemistry student can do it. And this begs the question of how much mercury is emitted from amalgams, and why hasn't the FDA demanded that somebody, an uninterested party, do this and estimate, or not estimate, but actually tell people how much mercury comes off of a one amalgam spill. Hasn't been done. Why is it critically important? If you take neurons in culture and you treat them to nanomolar, that's 10 to the minus 9th molar levels. And in a study published in the JADA, the Journal of the American Dental Association, they showed that the mercury in the brain of people with Alzheimer's disease and certain controls is in the micromolar range. That's 1,000 to 10,000-fold higher level than causes neurons to die in culture. It is important. Now, I want to question the thing about the Alzheimer's Association that says mercury and amalgams have no contribution to this disease. This is a neuron, and the neuron's axon is held together by tubulin, as shown in this slide. I don't have a lot of time to go through and tell you all the details, but this is disintegrated in Alzheimer's disease, and it is caused to be disintegrated in any tissue, in animals, etc., that you expose to mercury vapor. And this slide shows the technology that we developed, used eminently by NIH even today, to look at the GTP binding to tubulin. And what you can say is that mercury, and only mercury, will cause the same biochemical photolabeling profile as you see in an Alzheimer's disease brain. Lead won't do this, copper won't do this, nothing but mercury will do this. If you take a dental amalgam and you soak it in water for just an hour, as I show on this slide, and you take a sample of that and you add it to the same brain homogenates, you get exactly the same effect as if you're adding pure mercury to that system. This indicates that amalgams do release toxic mercury, and this mercury, if it gets into the brain, can cause an aberration similar as you find in Alzheimer's disease. All of this data has been published in refereed journals. If you look at mercury in Alzheimer's disease, we can say that mercury has been shown to cause the following disorders. This is in a handout you'll get. I won't go through it, but if you look at this, it is total publications where we see it. It can produce neurofibrillary tangles. It can affect the tau hyperphosphorylation, and it can increase the synthesis of beta amyloid protein, which makes the senile plaques. In other words, mercury, and only mercury will do these things, and yet it's ignored by the NIH and several other people and say mercury can't be a contributor. What I would submit to you that while I would not make the claim that dental amalgams cause Alzheimer's disease, I would absolutely state that anyone that's carrying a significant number of amalgams for 30, 40, or 50 years would cross that thin red line into Alzheimer's dementia quicker if they had amalgam fillings. There's absolutely no doubt about that. It is a toxin. It has never been put into a biological system without it showing severe toxicity at the nanomolar level. And we have these slides that's all published, and there's a protein called glutamine synthetase that's seen elevated. This has been, I published this first, it's been repeated now by 2 different groups. It's considered one of the leading markers for Alzheimer's disease if they can get the diagnostic test reliable. And what you can say is that mercury, and only mercury, will inhibit this enzyme at the levels we're talking about. In addition to the glutamine synthetase, creatine kinase, an enzyme that is well known to biochemists to be exquisitely sensitive to mercury, is 95% inhibited in Alzheimer's disease brain. This has been published in molecular brain research. The genetic susceptibility, as Mr. Burke talked about earlier, they have beat this protein to death to try and find out why the ApoE4 is a risk factor. You understand the second highest concentration in the body is in your cerebral spinal fluid. The ApoE2 is a mercury buffer. The ApoE4 loses that buffering capacity, and that protein is being transported out of the CSF into the serum to be cleared by the liver to get rid of oxidized cholesterol. So it is a countercurrent movement to take mercury out of the brain, out of the cerebral spinal fluid. A publication from Germany shows that the blood level of mercury is 3 times higher in AD patients versus unmatched controls. And this is a paper that was published in JADA, has a kind of an unusual history. It was rejected by the Journal of the American Medical Association and the New England Journal of Medicine, but it was published. It had some conclusions that I disagree with, but one of the conclusions I look at, if you look at the level of the mercury in 6% to 15% of these people, they're in the 10 to the minus 6 molar range. If you measure the mercury in the brains of certain people, that's 1,000 to 10,000-fold times higher than is necessary to cause a neuron to die within a few minutes. So you can't say that there isn't proof that mercury can't get in the brain and can cause problems, and you have to ask the question, where does this come from? Why does it only appear in certain people? Because these were all nuns that lived in the same convent, ate the same food, used the same dentist as far as I know. That's the reason the study was done that way. And you look at this and you say, how come a certain percentage of these people can't keep mercury out of their brain? And it's genetics. This other disease, idiopathic dilated cardiomyopathy, that's the one where you find the young high school athletes drop dead playing football. Happens every year. You'll read about it several times. They have 178,400 nanograms of mercury per gram of tissue. That's 22,000 times higher than is in the muscle tissue or is in the heart tissue of other people. And why hasn't the NIH or the FDA jumped on this and say, where does this mercury come from and how does this contribute to the disease? Is it the cause? Is it an exacerbating factor? Or is it something that's there? But what we can absolutely say...
1 minute.
The other proof, here's a paper that was in the white paper they talked about. They said persons with 2.5 years after amalgam removal had about the same level of mercury in their blood as those with existing amalgams, which was significantly much higher than people who had never had amalgams before. And what that's telling you is that the human body retains a lot of mercury. It doesn't go out in the urine and feces, it's retained. When they chelated these people using Dr. Vasoposion's technique, the levels dropped 30 to 40%, but within 2 hours, it was back up. Now, the DMPS takes it out in the urine, so where did the mercury come in that replaced it? And what I'm telling you, this paper shows absolutely that there's a high level of mercury retained in the human body, and you can take it out of the blood for 2 or 3 hours. When you quit, it comes right back in because it's re-equilibrating. And this is absolute proof that we have mercury stores in the body that we don't talk about. This is the much ballyhooed...
Thank you very much, Dr. Haley.
Fine, thank you.
Thank you. Our next presenter is Dr. James Adams.
No.
No, I'm sorry. Am I sorry? Your name, please?
Good morning. My name is Pam Factor-Litvak. I'm Associate Professor of Clinical Epidemiology at the Mailman School of Public Health at Columbia University in New York. I'm here today to speak about my research pertaining to mercury-containing dental restorations, also known as mercury dental fillings. I have been asked to speak here by the American Dental Association, and they have paid for my ticket and expenses at this meeting. I've received no other compensation from them, and they have not seen this presentation before I'm giving it here today. As an epidemiologist, I'm trained to evaluate all aspects of research on a particular topic. There are certainly roles for both animal and human studies in the evaluation of possible adverse associations between substances, any substances, and health outcomes. Indeed, there's ample evidence from both the animal and human literature regarding elemental mercury exposure related to dental restorations. And I'm not here to quibble with that. There's clearly evidence that there is exposure from dental restorations, especially during chewing or the consumption of hot liquids. The question that remains is whether such exposure is related to the wide variety of health effects reported in both scientific and lay literature. I might add that the evaluation of safety is a little bit different from the evaluation of an adverse effect. In fact, if you want to evaluate safety, it's much more difficult, and that's due to a statistical subtlety regarding testing of null hypothesis. In fact, you need sample sizes much larger than the evaluation of adverse associations. As an epidemiologist, I'm also trained in particular in the conduct of observational research. And observational research, as opposed to experimental research or randomized clinical trials, is key in evaluating health effects in humans. As for many substances, such as cigarettes, it's ethically inappropriate to expose humans. But observational research also has a very key role in evaluating the health effects of substances that are not deemed to be harmful, because you get to study people in natural environments rather than selecting a group of people in for clinical studies. And in fact, that gives it more what we call external validity, or validity to a wider range of people. Between 1997 and 2000, I received funding from the National Institute of Dental and Craniofacial Research to conduct a cross-sectional observational study evaluating the potential harmful effects, and they were harmful effects in terms of subtle neuropsychological and neurological effects of mercury-containing dental restorations in otherwise healthy adults. This study was approved by the Institutional Review Board of Columbia Presbyterian Medical Center, and full informed consent was obtained from all participants. My colleagues and I evaluated 550 healthy employees at Columbia Presbyterian Medical Center. They were aged 30 to 49. Well, we evaluated both exposure and outcomes at the same point in time so that we couldn't actually say for sure that exposure preceded outcome. We assumed that most of the amalgams had been placed in the teens and 20s of these people, thereby exposure had occurred for at least 10 to 20 years. That was a key assumption of this study, and we felt that it was a very reasonable assumption of this study. Approximately half of the sample was in the 30 to 39 age range, and half in the 40 to 49 age range. And additionally, approximately half the sample were professional staff, and half were support staff. And this sampling strategy assured a representative sample of medical center of employees across a wide range of sociodemographic characteristics. Well, we called a random sample of these employees into our general research clinic, and during the approximate 90-minute visit to this clinical research center, my colleagues and I administered several examinations. First, we had trained dentists doing a non-invasive dental examination. So what they did, using just a tongue depressor and a lamp, they looked in their mouths and ascertained each tooth, and we charted the size, the type of restoration, the size, and the location of each restoration on the tooth. We did it for both amalgams, for composites, and for other resins. We also administered a battery of neuropsychological tests, which measured verbal and nonverbal memory, attention, planning, executive function, and motor coordination. We asked the participants to fill out self-administered checklists to measure symptoms of anxiety, depression, and other symptoms that had been reported in some of the anecdotal literature on dental amalgams. We also administered a lengthy questionnaire to obtain information regarding current and childhood social circumstances, demographics, lifestyle habits, dental habits, fish consumption, and medical history. We administered a very sophisticated measure of neurological integration, postural sway, in which the subject stood on a force platform under a variety of different conditions, and it measures how much you sway while you're standing still. We took a urine sample to obtain spot concentrations of inorganic mercury, which we then adjusted for creatinine to adjust for the urine concentration. And we also took a blood sample in which we measured concentrations of lead exposure as a possible covariate and serum creatinine as a measure of renal function, and I won't talk about those results today. Our results indicated no adverse associations between any of the measures of mercury exposure, meaning urinary mercury adjusted for creatinine, number of total amalgams in the mouth, and number of occlusal amalgams in the mouth, and any of our outcome variables. And these null associations persisted after sophisticated statistical adjustment of potentially confounding variables in the analysis. We did, as expected, find significant associations between the number of total amalgams and the number of occlusal amalgams and urinary mercury concentration, sort of bolstering what I said before, that there is exposure and measurable exposure. However, the amount of exposure was tiny, and indeed only 5 of our 550 subjects had urinary mercury concentrations over 10 micrograms per gram of creatinine. So from this, we concluded...
Thank you very much. Your time's concluded.
Thank you. Yes.
Have you published your results, and where?
These results have been published in Environmental Health Perspectives in 2003.
Thank you.
Our next presenter, could you state your name, please?
My name is David Lorms. I am a staff consultant to the American Association of Public Health Dentistry. I have no other interest in this particular issue. I would apologize for Dr. Watson's inability to be here due to family obligations. And we thank you for the opportunity to provide this statement. The primary mission of the American Association of Public Health Dentistry, AAPHD, is to improve the oral health of the public. For almost 70 years, members of the association have dedicated their professional work to improve the oral health of all citizens and in such way contribute to the overall health of our nation. Our specialty focuses on preventive oral diseases and assuring that the best possible treatment options are available to citizens. We accomplish this by keeping ourselves abreast of the most important scientific findings and using the best scientific evidence available in deciding preventive and curative options and in formulating policies and recommendations. We agree with Brown and Wells' assessment of the scientific evidence that there is no causal association between dental amalgam restorations and health problems. In the absence of compelling evidence that dental amalgam causes or contributes to health problems, it is important to consider the benefits of its continued use in dental practice in the U.S. AAPHD is strongly committed to the use of effective measures for the primary prevention of dental caries, but this is not always possible. Tooth decay, dental caries, can lead to the loss of dental function, pain, disability, and tooth loss. Timely restoration of decayed teeth with durable restorative filling materials can prevent the loss of dental function and tooth loss, thus enabling a person to regain oral health. Tooth decay remains an important health problem in the U.S. The most recent published national data revealed that more than 16% of adolescents aged 12 to 15 years and 23% of adults aged 20 years or older had decay lesions in their teeth that have not been treated. More importantly, there are significant health disparities. Twice as many children and adolescents from families with lower incomes have lesions that remain untreated compared with those families with higher incomes. The disparity by family income is even greater among adults and seniors. Part of the problem is that despite societal efforts, more than 108 million Americans do not have dental insurance. Thus, the cost of dental treatment is a barrier to timely receipt of dental care. Because of its durability and other clinical characteristics, dental amalgam restorations are less costly than other alternatives. Were dental amalgam not available, the cost of dental care would indeed be higher, thus the barriers to treatment would be greater. In consequence, the American Association of Public Health Dentistry is concerned that eliminating dental amalgams as a restorative option for tooth decay will, in fact, increase the proportion of U.S. citizens not being able to regain oral health status and suffer from its sequelae. It is clear that the continued use of dental amalgams will have an important health benefit at the personal and societal level and should remain as a restorative treatment option. The final decision regarding its use should be left to patient and provider. Thank you.
Thank you for your input. Our next speaker is Mr. Jay Grant.
Thank you. My name is Jay Grant. I am the Legislative Counsel to the National Association of Dental Plans. I thank everyone for the opportunity to speak today. On a personal note, being in the Air Force and having my entire mouth full of amalgam, I duly hope it is okay. NADP is a nonprofit trade association focused exclusively on the dental benefits industry. The membership comprises over 70 companies, 111 million Americans with dental throughout the United States. The dental benefits industry relies on the scientific literature along with the experience of the dental profession in setting dental benefit levels for its policies. Dental directors and consultants who have been practicing dentists and broad-based dental advisory committees are key contributors of recommendations regarding dental benefits coverage for particular procedures or materials. NADP's volunteer groups that include dental directors and other professional relations staff of dental plans indicate that amalgam is the most studied material use today for dental fillings. The historic scientific literature from the Food and Drug Administration, the Centers for Disease Control and Prevention, the U.S. Public Health Services, the National Health Institute supports the efficacy of amalgam fillings, as well as a recent study published by the Journal of American Medical Association, which focuses on different aspects of child health, including neurobehavioral, neuropsychological, and kidney function, concluded that there are no measurable adverse effects of dental amalgam fillings on children. Amalgam is also the most common material covered by dental benefits for posterior fillings since the inception of dental benefit programs in the early 60s. This is because dental amalgam is durable, resistant to wear, relatively inexpensive in relation to other materials. Thus, it is the most effective material for posterior teeth where the chewing loads are the highest and the area of restoration is difficult to keep dry. Largely for cosmetic reasons, other less stringently tested materials such as composite resins may be covered by benefit plans for anterior teeth. However, the cost of these materials ranged across the country from $40,000 to to 60% more than the cost of similar amalgam fillings. NADP recognizes that the ultimate decision on the type of filling material to use is between the patient and the provider. The dental benefit industry's role is to facilitate access to care by relieving some of that cost. The Surgeon General's report, Oral Health 2000, concluded that the cost was the top barrier for assessing dental care, reported that dental benefit coverage increased the percentage of the population seeking dental care by 20%. Thus, reduction in dental benefits coverage result in reduction of dental care. The 2005 NADP Purchaser Behavioral Study showed that 71% of employers offered dental benefits, with the largest number, over 90%, among employers with over 1,000 employees. The following year, the dental benefit short enrollment found that 97% of all dental benefits are provided through group policies. However, the rising costs, particularly for medical coverage, are pushing more of the costs, including dental coverage, to employees. NADP member companies surveys show that more than two-thirds of groups and individuals cite the cost as the primary factor for selecting a particular dental benefit plan. No other factor, even personal dentist participation, ranks as high. For this reason, expanding dental benefits with new coverage or higher annual maximums or eliminating lower cost treatment options, such as dental amalgams, can have an adverse effect on coverage decisions and ultimately access to consumer care. Providing dental benefits for the lowest cost, effective treatment, which includes amalgam fillings, keeps cost affordable. In 2005, approximately 10% of the 21 billion in claims paid by dental benefit carriers were fillings. These costs were roughly equally divided between amalgam and composite fillings, with the costs of these corporate composite fillings averaging 50% higher than amalgam. The elimination of amalgam as a filling material, absent reduction in coverage levels, would increase the overall cost of claims for dental procedures by 2.5%. That would equate to more than $500 million annually. If this cost were passed on to the consumer through premium increases, it would be more than the total dental premium increases levied upon the industry in the last 2 years. With costs being the top factor in selecting dental benefits, costs increase at a level that could easily reduce dental benefit coverage below 55% of the covered population. With that and the time, I believe the rest of my testimony has been submitted. Thank you very much.
Thank you very much, Mr. Grant, for your input. Our next speaker is Dr. Felix Lau.
Good morning. My name is Felix Liao. I'm a dentist with 29 years of clinical experience. I pay my own way here, and I represent only that ideal to help patients get well and stay well, mouth, mind, and body. Unlike other ADA dentists that got out of the box, inside that box is the old world of ADA's mercury amalgam dentistry, with its disregard for the fetus and the environment. Outside that box is the brave new world of biological medicine-dentistry. One word, because the body draws no departmental or party lines. I'm here to share with you that view from outside that old box, which includes letters from, well, I will also include letters from patients who have recovered their health by going down the mercury-free path using safe mercury practices of International Academy of Oral Medicine and Toxicology. My patients and I wish to salute the FDA for revisiting the mercury amalgam issue now, and to thank all of you panel members for considering mercury amalgam's toxic effect on the human peripheral and central nervous system. As a mercury-free, mercury-safe biological dentist, I see many patients who have struggled long and suffered horribly. These patients do not want to return to the ADA dentist. That's why they never see them in their office. These patients are often at the end of their ropes as well as their hope. Mary Puff from Minneapolis is a typical example. She writes this letter to be entered into the record of this hearing as part of my statement, Exhibit 1. As you listen to this abbreviated version, please ask yourself, what needs to change to avoid more of these, more of the same? Mary Puff: I was diagnosed with multiple sclerosis, in quotes, by 3 neurologists at the Mayo Clinic and Minneapolis Clinic of Neurology after MRI revealed multiple lesions in my brain's frontal lobes. I asked one neurologist if he ever read any research on the link between amalgam fillings and autoimmune disease. He summarily dismissed me. I don't have to do any research. Amalgam toxicity is a fact, just like bee venom. At 42, I am forever relegated to a wheelchair? I don't think so. I took immediate action. I fired my Mayo Clinic neurologist and hired a mercury-free biological dentist. On the first day of amalgam removal from my lower right quadrant, a week after declining the wheelchair, my paralyzed right hand suddenly opened while I was still in the dental chair. On the first day of chelation, upon getting a DMPS injection, my proprioception and balance snapped back, and I tossed my cane into a corner. I never retrieved it again. From bedridden paralysis to the bathroom on my hands and knees, I now give speeches about mercury recovery around the world, in Europe, US, and in the Arab Gulf. Literally back from the dead, I, Mary Puff, do not intend to remain silent about this iatrogenic poisoning. How can this happen? And that's the end of quote. How can this happen if published study concludes that mercury amalgam is safe? Is Mary Puff simply an inconvenient exception for the old box of mercury is safely being used for the last 150 years? If Mary Puff's case is too far out of the average, maybe this next case of JT of Centerville, Virginia will be closer to home. I'll just read the highlights from her letter. As a result of childhood trauma, heredity, and who knows what else, I have always been a highly sensitive person mood-wise. This condition intensified in my adolescence, especially at the age of 15, when I had 5 or so mercury fillings put in my mouth, all at once. I remember being very depressed, starting around that age. I was a good student, so I was able to muddle through somehow. But I certainly wasn't a happy person. At midlife, 46, I've been through 20 years of intervention, such as therapy, meditation, medications, many alternative holistic approaches, such as body work, holistic psychiatrists, trauma work, and energy psychology, and so on. Over the years, I've evolved to a highly organic lifestyle that by all means, by all counts, will be considered well above the average in terms of health and fitness. However, I still have recurrent gloom and pessimistic thoughts that obsessively whirl in my head. I could work on them and get temporary relief, but they always add back in. I struggle with mood issues continually, and most recently, before getting my mercury fillings out, I experienced mood instability, irritability, and recurrent obsessive gloomy thoughts, and, such as people I love getting hurt. The changes I've experienced from getting the mercury fillings out of my mouth have been subtle and yet profound. Even after half of my mercury fillings was removed, I felt immediately as if a charge has been turned off from my nervous system. The benefits continue with the rest of the mercury removal. I find that I'm no longer obsessing over worrisome thoughts. This isn't to say that I still don't have such thoughts in reaction to expected circumstances. However, they don't plague me or swirl in my head. It's like now I can't even make myself obsessive anymore, even though I do try. The other mood improvement I've noticed is that I don't feel irritable. Even when circumstances irritate me, I find myself shrugging it off. It just doesn't stick in the very recent past, so that I would get irritated and I'd be clenching my fist and muttering under my breath, almost screaming internally. The reaction is simply gone. No matter what conventional medical experts say, mercury is not good for the human body. Okay. What can we conclude from the living proof of these cases? And of those who have testified as survivors, time only allows me a few bullet points. Please keep these in mind. 1, mercury-free dentistry is good medicine. As Dr. Huggins pointed out yesterday on cholesterol, and as Mary Puff's case comeback shows, shouldn't the medical community and the FDA sit up and pay attention? 2, mercury amalgam dentistry is catastrophic medicine and catastrophic economics, as you have heard testimony and tapped in from recovered and suffering patients alike in the last 2 days. 3, mercury-free dentistry can help reduce and even reverse neurological deficits without side effects without relapse, as living testimonials have shown. Isn't that good medicine? 4, mercury amalgam is
Thank you very much,
cost
Dr. Liao.
Thank you.
Thank you for your time. Our next presenter is Ms. Freya Koss.
We're just trying to figure out how this works. There, say go to slide. That's right, that's what you want. Yeah, that's what you want, number 1. Sorry. It's not on. On the screen. My name is Freya Koss. I am one of untold numbers of consumers who have sustained neurological and other illnesses resulting from placement of amalgam dental fillings. In March of 1998, I was among the majority of dental patients unaware that their silver fillings are 50% mercury. 7 days after having an existing amalgam filling drilled out and replaced with a new one, I was suddenly struck with double vision, and within weeks, I developed drooping eyelids, loss of equilibrium, and ataxia, symptoms I had never experienced before. The double vision progressively worsened, and 9 days after the onset, my optometrist, alarmed by my condition, referred me to a neuro-ophthalmologist, stating that, quote, the sudden onset of double vision indicated emergent neurological problems. I later found out that she suspected a brain tumor or multiple sclerosis. Although lesions weren't apparent in brain scans, I was diagnosed with MS, lupus, and then myasthenia gravis, based on clinical symptoms, a 10,000 ANA titer, elevated rheumatoid factor, and liver enzymes. Having been told that there were no causes, no cures, only steroids to, quote, fix my eyes, I began the solitary journey to find out what caused this sudden onset of life-threatening autoimmune diseases. I was unwilling to accept a lifetime of chronic, debilitating illness, as I had seen friends of mine suffer for years and die of these diseases. Having received no hope from the medical profession, I spent 20 hours a day searching the internet, searching for answers. A woman from England gave me the answer. She had MS for 10 years, had 2 amalgams improperly removed by a dentist who exposed her to lethal amounts of mercury vapor, and was struck with double vision 7 days later. That was my answer. I had had an old amalgam filling drilled out and replaced 7 days prior to the onset of double vision. Slide 2. Working through the nights for months, I read hundreds of scientific studies and governmental documents. That's one of them. There was no mistake. I had been mercury poisoned. I learned that mercury in the form of vapor is constantly released from dental amalgam fillings, the fillings that I had been told were silver. I learned that MS, lupus, myasthenia gravis, and other autoimmune diseases had been linked to mercury exposure from amalgam dental fillings. 4. I learned that heavy metals such as mercury dental fillings can impair function of the skeletal muscle acetylcholine receptor and calcium channels to the motor nerve terminal, compromising the neuromuscular transmission, often diagnosed as myasthenia gravis. This information was never given to me by a physician. I had to find it myself. I learned from the research of Swedish neurologist Patrick Storterbecker that the route of transport from the upper teeth to the brain amounts to less than 10 centimeters. and that neurotoxins from the oral cavity can cause neurological symptoms such as ptosis or drooping eyelids, sclerosis, epilepsy, and myasthenia gravis. Dr. Stortebecker's book is available if you're interested in reading it. I had my amalgam fillings removed slowly and safely by a mercury-free dentist, and within a few weeks, the muscle pain in my neck and shoulders disappeared, leg rashes began to fade, and I slowly regained my equilibrium. It took 3 years for my eyelids to lift and other functions to return. However, I still experience occasional balance problems and have neuropathy of my feet and brow area, Raynaud's syndrome, and occasional leg cramping. I also have some double vision. I was mercury poisoned, and in all likelihood will be affected for the rest of my life. We are here today with the hope the FDA will listen to the public and examine the role they have played in fostering the belief that the benefits of using amalgam outweigh the risks, while not acknowledging that any risks exist, despite the plethora of research supporting the dangers. The FDA has allowed the continued implanting of mercury in the body, the second most non-radioactive metal, solely based on the anecdotal claim of its 150 years of use, with no classification or proof of safety or efficacy. Neither the FDA nor the ADA have done actual research on the safety of amalgam, but claim they are safe. One must wonder, is the mouth the only safe haven for mercury? White paper. In deference to the FDA drafters of the white paper with regard to the World Health Organization's position on dental amalgam, who has never taken a position on the adverse health effects of dental amalgam. However, they have reported that dental amalgam is the largest human exposure to mercury. In their mercury policy report of 91 and again in 2005, WHO, quote, confirmed that mercury contained in dental amalgam is the greatest source of mercury vapor. In summary, there is no need to use mercury in dentistry, considering safe alternatives and the mounting evidence of harm. It is incumbent upon the FDA to protect the public, at once mandate informed consent, accurately classify mercury amalgams as a Class 3 implant, give warnings for children and women of childbearing age, ban mercury fillings for pregnant women, and uphold the precautionary principle. Do no harm. Abolish mercury in dentistry. Thank you very much.
Thank you for your presentation. Our next speaker is Ms. Sandra Duffy.
I'm president for Consumers for Dental Choice. I'm a government lawyer from Portland, Oregon, and I have no financial interest in this matter. The FDA is telling you that your job is to decide to agree with its white paper or to tweak it in some minor way. FDA is apparently trying to resurrect its 2002 proposed rule. The draft rules proposed special controls date from 1991, and therefore, and I'm not making this up, warns patients of amalgam's zinc content, not its mercury content. That's shocking for a health agency, isn't it? But that 2002 proposal is dead, legally dead. It requires a legal panel recommendation before classifying, and it has none. The one done in 1993, before all the bans and limitations on mercury products were done, is obsolete and did not follow FDA rules when it was done. Repeat, before FDA classifies, you must recommend. If FDA staff thinks otherwise, they need to get legal advice. If they have gotten legal advice before, you would not have needed to sue, we would not have needed to sue them earlier this year before, for failing to classify amalgams. We urge you to call a meeting promptly to take up the classification issue, and the only one you can do with the state of the science today is a Class 3. Today you can act on a narrow question, ban mercury fillings for pregnant women. FDA's failing to act on this issue is scandalous. FDA refuses to classify. It has never classified encapsulated mercury amalgam. It has never done an environmental impact statement on this, the largest source of mercury in wastewater treatment plants. It refuses to require proof of safety by manufacturers, a step that one of them has admitted to shareholders it cannot meet. It adopts a sham substantial equivalence test, and the Department of Justice has now admitted in court that FDA is applying a substantial equivalence test that it has never adopted. The Commissioner never made an order of substantial equivalence, says the Justice Department, but FDA is approving the product as if there were one. Why? Any one of these steps, environmental impact statement, classifying, proof of safety, all leads directly to the end of amalgam. So FDA ignores its legal duty to do any of them. Small wonder that the FDA jumped the gun last week, rushing to press the announced mercury fillings are safe even before you have met. Are they saying the fillings are safe for pregnant women who live near power plants or who are raised on tuna fish? Michael Crichton, the physician turned novelist, said, quote, "The system works against problem solving because if you solve a problem, your funding ends," end of quote. The ADA is using a product from the 21st century that medicine abandoned in the 19th century. The Consumers for Dental Choice Council, Charlie Brown, proposed to ADA counsel Peter Sviskus last April an exit route for amalgam. ADA would say, due to environmental reasons only, it would stop endorsing the product after, say, January 1st of 2007. Brown offered a meeting and asked for no money at all. ADA refused. ADA remains the only health group in the nation endorsing mercury in a health product, and again, an unnecessary product. If this panel review will be used by the FDA for a new proposed rule, FDA cannot limit your literature review to just the last 10 years. All of the literature which precedes a prior review, the FDA is trying to lock up. FDA is desperately trying to avoid having you consider the VIMI studies of sheep and monkeys, showing radioactive mercury amalgam dispersed throughout the bodies within 30 days of implantation. The ADA says animal studies don't count. That is a scientific foolishness, as Dr. Feigl of the FDA stated in the testimony film clip you saw yesterday. He admits animal studies are used to set policy and safety levels. Certainly, we aren't going to experiment on pregnant women to determine the percentage of mercury-damaged babies. In 28 years of trial work, my job was to marshal evidence to show a fact had been proven or that it had not been proven. You've heard evidence that mercury vapor is emitted from amalgams far in excess of government safety levels. Dr. Haley testified about this. Studies show there is no safe level of mercury. For example, Kazantzkis' work. FDA always cites the 1993 USPHS report on mercury to support its claim of amalgam safety. But even that report states that amalgam is one of the two largest sources of mercury. And the 1999 report, which they never mention, states that there is no scientific proof of safety for amalgam. You've heard evidence here yesterday and today that mercury is absorbed into the body. The VIMI studies show that. And that 1 out of 8 women giving birth have so much mercury in their bodies that their babies are at risk of brain damage. 1/3 of dentists are mercury-free, which is proof that amalgams are completely unnecessary. Consumers for Dental Choice conducted a survey about Medicaid payments. Every state responding said it would pay for alternatives, but patients just aren't informed of this. I am going to be giving these 4 CDs to the person who takes the submissions, and I'm going to place them in the record. They are scientific study submissions from experts in the public in the 2002 proposed rule process to make them of record. I specifically want to point out that since 1957, studies have shown amalgam causes
1 minute, please.
periodontal disease. I'm just going to sum up then here and say that the testimony of the last 2 days make clear that change is needed in government's untrammeled approval of mercury fillings. The only group still supporting it is pro-mercury dentists. Of course, changing work habits isn't easy for any of us, but mercury fillings simply aren't needed to fill cavities. The starting point to phase out these products that pose a risk to human health and ruinous to the environment is to protect pregnant women now. Amalgam exposes pregnant women to mercury. On that, every federal agency, CDC, U.S. Public Health, even FDA agree. The health of unborn children must come before dental economics. Please ban mercury fillings for pregnant women. Thank you.
Thank you for your testimony. Our next speaker is
I'm Dr. Steve Marcus. Yeah. I'm Dr. Steve Marcus. I've been a practicing dentist for 31 years in Haddon Heights, New Jersey, and I'm here on my own nickel. I've been a member of the ADA for those 31 years also. Hopefully this conference will mark the fulfillment of a quest that has taken more than 15 years. That quest is to be proven prudent in erring on the side of caution. We have heard that expression, erring on the side of caution, several times yesterday from the Canadian and the Swedish speakers. Let me tell you about my quest. While at the University of Pennsylvania School of Dental Medicine, my mother got into the habit of sending me clippings from the Sunday Times. Once a month, I got a big fat envelope of clippings. Then, probably early 90s, I got one envelope that changed my professional life. In it was an article about the Vimy study in Calgary. When I read the words of Alton Lacey, president of the ADA, as you recall hearing yesterday, that this was not a human study, I wondered what the ADA's agenda was. I stopped placing mercury fillings that day and have not done so since. I began thinking about the storage of mercury scrap. The ADA told us we had to seal it in a glass jar under antifreeze or another high specific gravity fluid. But the ADA also told us, out of the other side of their mouth, that it was totally safe to put in an American's mouth. So why did that amalgam scrap eat a hole in the metal lid of the jar that had the antifreeze in it? What was it doing to my patients? I thought about the environmental impact of mercury that was going through my suction and out into the sewer system. I installed a separator on my building, and now every year we proudly recycle between 3 and 5 pounds of mercury that otherwise would have become an ecological bioburden. At the beginning, it took a lot of time to explain the whole issue to my patients, the Vimy study, the story about amalgam scrap, and that I preferred to err on the side of caution. When properly educated, who in their right mind would choose mercury? About 20 years ago, the profession underwent a major paradigm shift when autoimmune deficiency syndrome came on the horizon. We had to treat everyone as if they were an AIDS patient, gloves, sterilizable or disposable instruments. Now another shift is in order. We must treat everyone as if they are one of the susceptible to mercury toxicity. We have heard repeatedly about the myriad symptoms and syndromes that are part of the diagnostic equation, the A to Z, from Alzheimer's to zygote abortion and everything in between. A member of the panel on this side, I forget who it was, yesterday asked a very salient question of Dr. Phillipson. What did he expect the epidemiological impact of eliminating the placement of dental amalgam to be in Sweden? Many pro-mercury dentists argued yesterday and then again today about the cost of eliminating mercury from their armamentarium. But nobody asked what the financial burden is on the medical system for symptoms resulting from the use of mercury implanted in people's skulls. Hopefully, if this body deems it correct to take the appropriate stance, we may see serious decreases in the amount that medical insurance has to pay for the treatment of chronic illnesses that physicians might otherwise attribute to factors other than people's fillings. Pro-mercury dentists argued yesterday and then again today that composite fillings are less durable and that dental schools can't teach it. This is all ludicrous. Dental schools teach dexterity and they teach technique. They also insist on the use of the rubber dam for all students. That makes the placement of composite resins a non-issue. It can be trained, and it should be done. It's the training of the faculty that is going to take a little bit of time, because there are a lot of dinosaurs still teaching in dental schools. The image of the fighting and screaming welfare child is the exception and not the rule. It is certainly not the reason you have to approve the use of mercury in children's heads, a substance that has no known half-life, as we have heard, and can cause symptoms 35 years later, not 5 to 7 years later, as the limitations of the study presented yesterday indicated. What needs to be done is that parents need to be educated that what they allow their children to put into their mouths is going to affect their spending money. The schools need to reform the foods that they offer. Soda machines need to be banned. Warnings need to be placed on Mountain Dew. Not to get off the topic, but if anybody has ever seen what dew mouth looks like, dew mouth is as disgusting as meth mouth. And we really need to educate the public so that the children don't get decay. I mean, we thought decay was going to be eliminated by this point in time. But you go into any convenience store, and people are just hitting the big gulp machines and drinking soda. So the issue isn't how much is it going to cost to put amalgam fillings in people's heads versus composites. The issue is prevention. How do you give informed consult that says, here's a list of 105 symptoms you might develop as a result of this filling I'm placing. Keep it in your wallet. It might be 30 years until they develop, but if they do, they're going to be tremendously debilitating. On the basis of the information provided, how many of you are willing to take the risk to have a large mercury filling placed in your mouth, in your child's mouth, in the mouth of the woman who's about to deliver your grandchild, in the mouth of somebody who doesn't even know that they're pregnant? How, therefore, can you allow it in the mouth of any American? I encourage you to consider taking a cautious and courageous approach. The ADA won't do it, the state boards of dentistry won't do it, and the dental profession isn't going to do it voluntarily. The act of placing mercury in the head of anyone, not just a pregnant woman or a young child, must be banned. How do you, the FDA, listen to all this information and apologize to future mercury cripples?
Thank you for your input. We're attempting to get the public portion. I'd like to clean up the list that we have here. Is Dr. James Adams here?
I'm supposed to talk for him. He couldn't make it. He asked me to deliver his talk.
And you're Dr. Haley?
Yes.
We had a discussion between the chairs on that. I mean, I would be happy to have a substitution for him, but someone who has not previously spoken. Could be from your group would be fine. But we would want to have, I mean, it would then be allowing you to have a second opportunity, which we have not allowed anyone else to have for you. But if you'd had someone else from your group who would like to speak for him, that would be acceptable. So if you want to take a moment, I would be happy to consider someone else, but just not you, because you've already had an opportunity to speak. Yes, could you come? Well, give me a moment then. Let me see if some of the other people we have listed here, and I'll get back to you in just a moment. Dr. David Sarrett? Is he present? Okay, we'll move on. Ms. Karen Burns? Okay, would you like to come forward? Yeah, she's in the back right there. She's spoken.
Hello. I'm here.
Could you state your name and?
Oh, yeah. My name is Karen Burns, and I was a dental assistant for 24 years until I couldn't work anymore. But I'm here to represent myself, to talk to you people, to ask you to please listen and please study this material so that other people won't have to suffer. So people in your family who might have this sensitivity might not have to suffer. Like that dentist before me just said, let's treat everyone as though they have the sensitivity, like we treat AIDS patients so that we don't cross-infect the whole public. Nobody knows who has the sensitivity or not. Nobody knows why they get this or not, but we do. This is a real thing. I've been sick for 8 years. If I could tell you what my life is like, it's really hard to even talk about it. Even the cure, like they said, with cancer, going for chelation treatments, not having any veins left. I've gone through 12 chelation treatments, and I'm still very elevated. When I first started dental assisting, we didn't wear masks or gloves. We had a bottle of mercury and silver pellets that we put together by hand. And you want to talk about vapors being in the rooms. Back then we even had rugs in the rooms because we didn't understand that these vapors were everywhere. This is a great opportunity for you people to consider this issue, even though they've been saying for 150 years that this has been a safe product. You must see the damage that it's doing. Even if it's doing it to 10 people, why should 10 people, which it's not, it's much more, why should anyone have to suffer this illness when it can be totally eradicated? We don't need to use dental amalgam fillings. So what if it costs a dentist another $20,000 on his practice? I'm sure he could absorb that cost, like the guy was saying from the ADA. You know, and why do poor children have to get stuck with amalgams? Is that right too? Why can't Medicaid pick up the difference in the cost? And this last dentist that spoke too, we need to educate children about soda and things. My children don't have cavities, you know, and if they did, I would never put amalgam in. I hope you people just listen and find it in your heart to really consider all of this. It's a real thing. Thank you.
Thank you for your input. Again, some people who had asked today, is Virginia Pritchard here? Mark Morin? Nori Oakes? Oh, okay. Are these the other? Okay. Dr. William Duncan? Yes. Okay, you come forward. Thank you.
I don't know whether somebody needs to bring the slide up that I was supposed to use. Yeah. I'm Dr. William Duncan. I served for 10 years for Congressman Iztuk from Oklahoma as the Appropriations Committee Associate on the Labor, Health and Human Services and Education Bill, overseeing the Centers for Disease Control. Today I'm a lobbyist and I have no interest whatsoever in the issue in any financial way other than as a former public servant and used to do FDA issues as well. My testimony is from a 2004 hearing, the last official hearing I covered for CDC, and I have a quote from Julie Gerberding, the CDC director, that is quite significant. We were talking about mercury in vaccines, and she stated,
Let's get to the basics. The basics are that mercury is a heavy metal. It is not something that anyone wants to have in their body if they don't have to. The steps that we have taken, we've all recommended removing thimerosal, which is 25% mercury, from vaccine supplies as quickly as possible. It's a prudent, common sense approach to the situation because we cannot prove a null hypothesis that it is not harmful. Further, I worked with Dr. Jim Perkel, who is the chief toxicologist at the Centers for Disease Control Environmental Health Sciences Lab, and he told me that the more he has studied mercury and arsenic and lead, the more concerned he has become over the public health impact of these metals, and mercury is the most toxic. I've been asked to cover how the release rate for mercury from newly made mercury amalgams. They titrated mercury amalgam using commercial single-spill samples under supervision of a board-certified dentist and stored samples appropriately. And the composition of the two alloys tested showed a significant increase in the amount of chemical composition of the two alloys studied. The old one at 50% mercury had a much higher release rate. Excuse me, the high copper alloy releases significantly more mercury than the old-fashioned low copper alloy, as the slides show on the screen. The analyzer results, the analyzer showed that only mercury is present in the emitted vapor, and it exactly matches the signature of pure mercury on the slides on your screen. Therefore, there is the amount of this is from a single spill filling, and most fillings are 1 to 3 spills, and the actual release rates in the first 4 hours could not be measured, so release rates on one day are presumably higher than reported. The mercury amalgams emit much higher levels of mercury during the first few weeks than reported in the literature for fillings placed years ago. High copper alloys, primarily in use today, release much more mercury than older style low copper alloy fillings. The amounts emitted during the first week are far in excess of the FDA guidelines for exposure to methylmercury. In vitro studies are needed to more exactly quantify the release rates from new fillings, and presently there is no data on vapor release rates from newly made fillings except for this study. This was funded by the Wallace Foundation and was a master's thesis paper for Jamie Argular at Arizona State University, and there's an article now in preparation on that basis. I would urge the committee to follow Julie Gerberding's recommendation, the head of the Centers for Disease Control, and come to the conclusion that nobody wants mercury in their body if they don't have to have it there. In my years of doing public health for Congress and overseeing the Public Health Service, avoidance of mercury poisoning is the one of the number one areas that the entire schools of public health, all 29 of them, continually work on to try to limit the exposure, because getting it out of somebody's body, as you've heard testimony here today from people who are poisoned with it, is very difficult and very expensive in the process, and usually not paid for by insurance. So it's important when 1 out of 8 children, as Dr. Perkel discovered, he's the one who did that study that EPA published, when 1 out of 8 children of childbearing age, women of childbearing age are toxic for mercury, it's having a direct impact on the entire education system. We're spending $60 billion a year to educate children in schools, many of whom are damaged with neurological disability from mercury poisoning. Thank you for this opportunity to testify.
Dr. Duncan, could I ask you a question? Could you clarify one thing? You said you were a lobbyist, but who do you represent?
I'm not here representing anyone except my own experience.
Okay. No, I'm sorry, you stated you were a lobbyist. And
I just stated that I was a lobbyist because that, I'm not working for Congressman Istook any longer.
Okay.
But I did that issue for him for 10 years. And this is something that I learned in 10 years, that
I saw all kinds of people with all kinds of chronic diseases come to me for NIH funding for this problem and that problem, and they were all kind of puzzling things. You can imagine my shock as I prepared for the 2004 hearing on mercury to realize that many of the symptoms that people were coming to me with were the exact same symptoms that showed up in mercury-poisoned patients where there was documented evidence directly from Harvard School of Public Health and other places. You know, you look at the symptoms of the people and all of a sudden you see psoriasis and you see neurological problems and you see chronic fatigue syndrome and you see autoimmune diseases show up, and these are all directly related, according to the case reports I was reading, to the mercury poisoning they received in a known dose, and we knew how much mercury they got. I can tell you I have had all my mercury fillings out, and I'm very glad to have done so, and did the same for my wife, and our grandchildren are next. So prudence on the part of the FDA. You guys have already removed mercury from teething powders. You took thimerosal off the market as mercurochrome because it wasn't safe to put it on topically. If you can't put it on topically as an occasional thing for a cut, why would you put some in your mouth that you just leave there for years?
Thank you for your clarification. Mr. John Rowe.
Good morning. I'm John Rowe from Oxon Hill, Maryland. I'm here as an individual, but in the interest of full disclosure, I did used to work for the House Committee on Government Reform and Oversight. I coordinated 3 congressional hearings on the subject of dental amalgam. On a personal note, several years ago, I was being treated at the University of Maryland Dental School, received 7 amalgams. There was no discussion about what kind of restorative material to use. It was just mix the amalgams, put them in. At that time, I had no idea what that was. 2 years later, I was diagnosed with chronic myeloid leukemia. Now, I can't tell you with absolute certainty that the mercury poisoning from the amalgam was the trigger for my leukemia. But I also, after reading thousands of documents, I can't tell you with absolute certainty that it was not the trigger. It very well could have been. But you know, all that experience makes me wonder, where's the informed consent? Why wasn't there some kind of a discussion of here are the alternative materials, the pros and cons, what are your choices? And then during the congressional hearings, this issue of the gag rule came up constantly. And while the ADA denies that there's a gag rule, there most certainly is in the eyes of many state dental boards. And various dentists have lost their licenses or were in jeopardy of losing their licenses because of discussions about the alternative materials and the mention of the fact that mercury is in the amalgam. Informed consent is an honored tradition in every other facet of medicine. Every other facet of medicine. Why isn't it a tradition in dentistry? And why, in fact, is it actually prohibited in many states in dentistry? That's a very puzzling question to me. It recently came to my attention that there's a controversy in the European Union about the transport of amalgam from the manufacturer to the warehouses and to the dental offices. Restrictions on the transport of hazardous materials is interfering with the free flow of the amalgam to its place of use because it's so hazardous. Many good brains in the European Union don't want it on the public highways. They don't want it on the aircraft. And of course, there are workplace rules for storing that amalgam until it gets used. And as you've heard several times, once amalgam comes back out of a mouth, it has to be handled as a hazardous waste. But yet, it's safe while in the human mouth. That that's another thing that just defies logic and defies common sense. I cannot reconcile that. And finally, and to be brief, the Institute of Medicine, part of the National Science Foundation, as you've heard before, estimates that at least 60,000 babies are born a year. Every year in the United States with the risk of learning disabilities because they've been mercury poisoned through the placenta from their mother and from their mother's amalgams. 60,000 a year. Now, it's not like we're giving these kids the common cold and they're going to feel bad for a week and get over it. We are imposing lifelong disabilities on these children that are going to adversely impact their quality of life and the quality of life of their extended family for many, many, many years. As a father of 4, a grandfather of 10, I'm a great-grandfather of 1 with another great-grandchild on the way, this just tears my heart out. If nothing else comes out of this conference today and yesterday, please act responsibly so we stop poisoning our babies. Please.
Thank you for your input. Mr. Ernest West.